Welcome to Adult Care Level 2, Understanding Mental Health. We're going to do this lesson in two parts. In the first part, we'll cover understanding the legal context of mental health and then knowing what's meant by mental health and mental ill health. The second part will be available on the channel as well, which will include understanding the social context of mental ill health and understanding how mental health care has changed over time. So, the first thing we're going to look at is understanding the legal context of mental health. Your first question in this section is identify relevant legislation in relation to mental health. So, before we go on, I want you to pause the video and write down all the legislation you can think of that relates to mental health. Give that 2 minutes. So pause now. Okay. So, some examples that I have for you are the Equality Act 2010, the Human Rights Act 1998, Mental Capacity Act 2005, Mental Health Act 83, the CARE Act 2014, and the Safeguarding Vulnerable Groups Act 2006. So this is an identify question. You just have to list relevant legislation. Right, so question 2 from this is outline how legislation informs provision of care for an individual with mental health problems. So working from the legislation that I'd listed on the previous page, we have the Equality Act 2010. Now that is the act that prohibits discrimination on a set number of grounds, including disability. Mental health problems and disorders, they would count under disabilities. We call something a disability if it is persistent over a long period of time and significantly interferes with your daily living. Now, depression, for example, would count if it is significantly impacting on the individual. It would count as a disability along with various other mental health conditions. So what the Equality Act means for the care of the individual is that we would have to ensure that we are being fair in how we're treating them, that we're making reasonable accommodations, that we're taking into account their disability when we are making accommodations. For instance, if we were working with somebody with a personality disorder or with, let's say, bipolar disorder might be an interesting one. If we're working with someone who had a mental health condition that might cause them to have some odd behaviors that might be disturbing to other people that we're working with, that might be disturbing to us, we would have to ensure that we are trying to accommodate them. Another one that would definitely be relevant is the Human Rights Act 1998. I've picked out Article 5 in particular as being very relevant. It's the right to liberty and security, meaning that you can't be detained without good reason and legal cause. Now, the Mental Health Act 1983 sets out the rules for when a person could be detained for mental health reasons and how, including, as I say there, provisions for appeals. So a person couldn't just be detained indefinitely with no appeals under mental health grounds. That is like how it used to be in the past, and it wasn't a very good plan because it would be very open to abuse. So under these acts, somebody has to be supported to make their appeals. The appeals have to be available. There are other factors under the Human Rights Act that would influence this as well. Like you could link this to the article on the right to private and family life. That article does cover a lot. It includes the right to privacy, it includes the right to basically be left alone, not interfered with. So in these cases, it is very linked. Now, the Mental Capacity Act as well is a very interesting one to look at. This is the one that says we have to assume everyone has capacity. If somebody has been determined not to have capacity, then we are doing that on a issue by issue basis. We usually wouldn't make a decision that people have no capacity whatsoever for any decisions ever. We'll talk about this more on the next slide. It comes into the next question as well. So we'll go on. Your next question is outline legal provisions for individuals who are unable to make decisions for themselves, hence the Mental Capacity Act. So if somebody may not have capacity, this act comes into play. It has 5 main principles, 5 main areas or rules that we have to follow. So the first one, the primary one, everyone is assumed to have capacity unless it's established that they don't or lack capacity in some areas. That's number 1. After that, a person should not be treated as unable to make decisions unless all practicable steps have been taken to help them do so without success. So that means that we have to try to explain all the factors to the person and give them the best chance to make an informed decision as we can. It means that we have to try and explain it to in their own language or their own communication method. If somebody was a British Sign Language user, for example, and didn't really use vocal language that much, just speaking to them if they can't hear and not trying to understand them or to get an interpreter in to interpret the British Sign Language would not have met this criteria. All practical steps would not have been taken in this case. A practical step is to get a translator in. If somebody has learning difficulties, we'd have to explain it to them in very simple language that they have that they would be able to understand. We have to try our best to change our approaches and help people understand and be able to make a decision. Now, this feeds into the next one very nicely because we can't treat someone as unable to make a decision just because they make the actual guidance says unwise decision. I would include odd or eccentric decision in that. So just because we think their decision isn't the right one, or it's odd, or they're doing something eccentric or a bit out there, that doesn't mean they don't have capacity. There are plenty of people with full capacity that do very odd things all the time, or things that maybe I don't get or you don't get. Like if we got into a room, I'm sure there are things that I do that you wouldn't get, and there are things that you do that I wouldn't get. That doesn't mean either of us lack capacity. It's very important to know and to understand and to act on the fact that people make different choices. For example, drinking. I wouldn't drink alcohol normally, and I would consider it to be a less than good decision in general to be drinking alcohol. There's very few benefits to it. I know it's a very social activity for a lot of people, but it also carries a lot of risk. But if people make the decision to drink alcohol, that doesn't mean they don't have the capacity to make that decision. That is the decision they've made, and that's fine. Next one, our 4th principle is that any acts done on behalf of the person or decisions made on behalf of the person who lacks a capacity must be made in their best interests. So this means that it has to be best for that individual. It can't be beneficial primarily to family members. Let's say if the decision is to sell the family home and that the individual goes to live in a care home. Is that decision in the best interests of the individual? Are they going to be better off in the care home? What happens to the money from the sale of the family home if the family home is theirs? It should, I would think, go into an account for them to pay for their care and their needs. That would be in their best interests. And the last one is the least restrictive practice. Whatever decision is made, it has to be the least restrictive option. If somebody lacks capacity and is known to wander, the least restrictive option might be to have the front doors locked or the outside doors locked. But would it be appropriate to lock the internal doors? I would argue no, unless there's something clearly unsafe in the building. If external doors are going to be locked, you do have to have a person present. You can't just lock somebody in and take the keys away. That would be entirely wrong and very risky. What if there was a fire? So we have to have the least restrictive options in place. Okay. Your next question would be to outline the legal principles of confidentiality and data protection in relation to individuals with mental health problems. So, with this, the same rules apply for confidentiality and data protection to individuals who have mental health problems as do to someone who doesn't. The Data Protection Act still applies. The Equality Act, which says we can't discriminate, definitely means that this applies. We can't treat somebody with a mental health problem differently for data protection because of their disability than somebody who doesn't under the Equality Act. If we did, that would be discrimination and would be in breach of the Equality Act and the Data Protection Act. So we don't want to do that. Now, the Mental Health Act 1983 does have provisions in it for when you can share information or when medical professionals can share information about somebody's mental health. This is to allow for when somebody is in a dire situation and would need to go into hospital, but they may not be in a good position to agree to that themselves. So this allows for doctors and psychologists and professionals to share information to try and make the decisions in the best interest of the individual. The Mental Capacity Act I've put down there as well because we are assuming that people have the capacity to make their decisions. So in general, if somebody is deciding that they don't want their information shared, then you would assume that they have the capacity to make that decision and would therefore not share it. If we have followed all the principles of the Mental Capacity Act and it does appear to be in the person's best interest and very necessary to share information, then you could do that. I've included the Terrorism Act 2006 there as well because it could apply. If you saw somebody if you were helping somebody who maybe you noticed the usual example I give is you notice them watching bomb making videos or other what might appear to be extremist material. In those circumstances, you need to report it to the prevent channels. We have a responsibility to report any sort of possible terrorism related activity in general for general safety. But if we're working with somebody who has mental health problems or other problems, they're a vulnerable person and very possibly they could be being led down the wrong path, and it would be in their interest to report it and try and divert them before anything bad happens. Okay, so those are some examples. Now, on to, this is section 2, know what's meant by mental health and mental ill health. Now, the question here is, the first question in this section is to define mental health and mental ill health. So pause again for a minute and write down what you think those are. Okay, so the Oxford Dictionary says that mental health is a person's condition with regard to their psychological or emotional well-being, which is fine. It's a nice tight definition. It gives you a fair idea straight away. But the WHO, the World Health Organization, they've gone a bit further. They've said that mental health is not just the absence of a mental disorder, it is defined as a state of being, of well-being, in which every individual realizes his or her own potential, can cope with normal life stresses, can work productively and fruitfully, and is able to make a contribution to his or her community. Now that one goes a little further, and it seems to me from reading it that there are shades of Maslow's hierarchy of needs in there, that the first thing we need to do is to be well, and then to seek fulfillment and self-actualization, which does give a better idea of what mental health would actually be about. I do prefer definitions of mental health that don't just say that it's the absence of mental ill health. That this one, the WHO's definition, I think is a little better because it does seem to have some positive goals included to be healthy. Now, we also have a little information on mental ill health here. So mental ill health, it's generally a broad term. It's just a broad negative state of mental health. And it could be split up into kind of two areas. So we've got mental illness is often said to be a diagnosed mental health condition, like bipolar disorder or major depression, whereas mental health problems are often said to be like lower level interference with someone's emotional, cognitive, or social abilities. It's usually shorter and less severe. But as I've said there, if it is ongoing, it could develop into mental illness. This is why early intervention is the key, and being aware of mental health is key, because often mental illness doesn't start at the diagnosable level. It starts with little things like feeling down or loss of motivation, and at that stage it would be a lot, I'm not going to say easier, but less effort, less troubling comparatively to make a difference in it. Okay, so next question in this section is describe the characteristics of mental well-being. For this, different sources seem to agree that being confident and having self-esteem, or good self-esteem, is fairly key characteristics of mental well-being. It is notable, let's say, from, let's say, symptoms of different disorders like anxiety or depression, that low self-esteem seems to be a factor. So having good self-esteem is thought to be a factor of well-being. Coping skills is another factor, certainly. If people feel that they are able to cope and have the skills to cope with what life throws at them and to adjust to changes and shocks, and they would then be able to maintain their mental well-being better. Um, we've put feeling engaged in the world around you there and living and working productively. It does seem to be a factor. Isolation and loneliness seem to be a factor in various mental health conditions. So being engaged, we know that unemployment or job loss or loss of social relationships, that these are all factors, potential triggers for mental ill health. So maintaining social relationships would be a protective factor or a characteristic of good mental health. Let's see, we also have down there ability to learn or express feelings. These are also definitely characteristics of good mental well-being. You would often find, if you talk to people who have mental health problems, they'll often tell you that they found it very hard when they were like starting down this path, or on their bad days, that find it very hard to describe what's going on or talk about their feelings or engage with other people and ask for help. Being able to do this, it is a characteristic of good mental health. Okay, so over here we've got described risk factors associated with developing mental health problems. There are several. I've given you a few examples here. So we have if you've got a family history of mental ill health, that can be a factor, like a risk factor. Depending on the condition, depression, for example, is thought to be up to 40% or so genetic. So if a close relative, like a parent or a sibling, has depression, then the individual's risk would be higher. Other conditions have high genetic risk factors as well, including schizophrenia. The other part of that is the shared environment. If, let's say, siblings with a year or two between them, they would have very similar environments growing up. They'd have this well, let's assume for a second, the same parents, same household. They'd be interacting with the same people. They might go to the same school. They probably wouldn't have the same friends necessarily during the day, but they might if they're in the same school. That is a lot of shared time and shared experience that would account for some of the risk as well. You have stressful life situations, financial problems, divorce, or death of a loved one. These are known to be triggers. They're very stressful. They could trigger anxiety, depression. People might not know how to cope, and it could trigger a bit of a downward spiral. Use of alcohol or recreational drugs. I've explained there how alcohol causes dopamine, which is a reward hormone in your brain, to be released. Now, over time, you'd need more alcohol to release dopamine and get the same kind of happy reward feeling. But alcohol also seems to deplete the dopamine that's available in your brain or interfere with the uptake. So it doesn't give the same effect over time. So people still keep chasing that feeling by drinking more alcohol, but they're not getting the same effect. Alcohol also interferes with sleep. So we all know that diet and sleeping patterns do play into better mental health. If people can't sleep, they're more stressed, the brain can't recover, the body doesn't recover, people feel more worn down and are more susceptible to both physical and mental illnesses. For recreational drugs, they can have similar effects to alcohol on the hormones in your brain. They also could potentially lead to drug-induced psychosis. So that's where people end up hallucinating or with delusions, and sometimes people come out of it quickly, sometimes people don't, so it can be very serious. Traumatic experiences, such as, for example, people living with wars or surviving wars, that can lead to PTSD. Also, traumatic experiences can lead to anxiety. What we mean by traumatic experience would vary by person. Let's say if someone is mugged on the street, they might become anxious about going outside. If they avoid going outside for such a long time, the anxiety could build. They might develop something like agoraphobia, where you're afraid of open spaces. And then we have ongoing chronic conditions. So any chronic illness or condition could be counted here. Key ones that I think of: back pain, IBS, Crohn's disease. Anything that leads to pain takes a lot of energy for people to deal with that might normally be going on their coping skills, for their the psychological or emotional items that they have to deal with. If that energy is going on managing pain, it's not there to deal with the psychological stuff, and as well as pain interfering with sleep and with your life and with let's say your social interactions or your job. It all leads to stress. It very easily leads to anxiety or depression. You would often, with severe pain patients, you would often find a high rate of depression. Diabetes as well is another one. 40% of people with diabetes say they've struggled with depression since their diagnosis. Now that's 40% in the UK, those are UK statistics. It could be for a number of reasons. It could be an adjustment. It could be, if it is diabetes related to diet and exercise, then it could be a certain amount of guilt over getting into this situation. It could be worry about being a burden. A lot of people with physical conditions worry about being a burden, and it just adds to the stress. So, moving along. Next question is identify examples of mental health problems. Now, in this, I've given both mental health problems and some mental health conditions, just to be clear on the question, since it didn't define whether it wanted like everyday mental health problems or if it wanted mental health conditions. So we've included stress, grief, intoxication. Intoxication is actually in the Diagnostic Statistics Manual as a condition, so it's there. Feeling down, persistently feeling down, suicidal thoughts, difficulty concentrating, low motivation, lethargy and fatigue. And then we have potentially depression, anxiety, addiction, psychosis, schizophrenia, let's say personality disorders. There are several you could choose from here. Pick a few from each. Make sure you include some that would be in the lower end of mental health problems, and then some conditions. Right, and that's the end of part 1. Thanks for listening.